Hey everybody, this is the Progress Report. And because, believe it or not, this is the first Wednesday in March, I have my good friend Lou D'Alessandro with me.
Thank you, Robert.
While Mike Farley is off being a good, ancient,
Hibernian.
honorable hibernian, getting ready for the greatest parade in the city of Manchester, coming up not on St. Patrick's Day, but a little bit after that. And so here we are, and I have to thank my good friend Lou D'Alessandro, who contributes in so many ways, in so many areas, for the selection of our guest today. And our guest is a representative of the Manchester Department of Public Health, Bill Alexis.
Phil Alexikos.
Phil Alexikos.
It's a nice Irish name.
Right.
A wonderful Irish name.
Well, classmate.
We
of my
love
da-
it. And
classmate of my daughter Christina's.
and apparently, just hearing Lou say that only Manchester and Nashua really have significant public health departments, and we all know that we have faced some really severe challenges with public health now. I mean, we've had past challenges with public health from the SARS epidemic, and it seems to me that our public health system has performed admirably in dealing with those things. Now we have perhaps as great a challenge as we've ever had, and we couldn't be more pleased to have you here with us, Phil, and I thank you, Lou, for providing this program.
I think
So take it away.
I think it was timely. We're blessed to have a wonderful health department in the city of Manchester, and once headed up by Tim Soucy, now Mrs. Thomas, who's magnificent also, and Phil does just a great job. But what both Mom and I would like to see is what's going on. We sense that there's a problem nationwide. Our president underplays it, but that's nonsense as always. But in reality, there's a problem. We just had another case recognized in New Hampshire, just today, and across the world, I mean, the problem in Italy is severe. I talked with my family in Milan. They've closed the schools for 2 weeks. They're even threatening on closing businesses. So give us an indication of what we in Manchester are doing and what's happening in the state, so that people can be confident that we know what's going on, we know how to take care of it, and we're putting our best foot forward in defense of the public.
Well, thank you, Senator and Representative, for having me on the program, because this is a very timely topic, and folks, really, I would caution them to stay tuned on a daily basis, because this is a novel coronavirus. This is a new strain or variety of the virus, and we're learning every day.
When you stay tuned, where should they stay tuned to?
Excellent. So that's a really good point. So the best place to go for information in New Hampshire is to the Department of Health and Human Services website. And they have a novel coronavirus, also known as COVID-19, webpage. And on that webpage, they are cataloging and updating all of the pertinent guidance documents, and they are putting out advisories to different stakeholder groups. So there are clinical guidelines that are going out. Those are often known as HANs, or health alerts, to give clinical information to providers on testing, screening, isolation, quarantine, those types of things. There are also public press releases, because certainly there's a lot of attention and concern and interest, and so they are putting out general press briefings with case information, testing information as the situation evolves. But we're trying to direct people to one place because we can update information there so that folks don't have to go moving from place to place. So, you know, that's what we want folks to do, and it covers all of the different stakeholder groups that could be impacted. And when we have something that is a pandemic, and by pandemic we mean an illness that is spread worldwide, meaning pan, and at a level that we don't expect, and we certainly didn't expect to see this novel coronavirus. So we are working very hard to improve communication, but we want to condition the public to know that guidance will change, and that's very difficult for people to digest and to accept. And sometimes when guidance changes, it's perceived as they don't know what they're talking about, and
Right.
we do know what we're talking about. We're going with what we know at that moment, because it is a changing situation. You know, we learn more about this particular illness, who's more or less at risk, what countries are having an issue, and looking at that data. And just today, there was a change in guidance and today's March 4th, that Italy there's 3 levels
Yes.
of travel concern. They were just elevated to a level 3,
That's
which
the highest level, isn't it?
that is correct.
Yes.
So there are
Wow.
countries, China, South Korea, Italy, and Iran are all experiencing illness at a level that means that there's more than widespread person-to-person transmission documented. And then level 2 is what they're experiencing now in Japan. And each of those levels, or risk levels, if you will, come with particular travel guidance. That's not only you shouldn't travel to those countries, but also what happens when you come back into the country. And so each of these, risk levels has certain surveillance and information attached to them.
What let's kind of describe what is the virus that we're dealing with.
So coronavirus is a group of viruses that is known to us. It's not something that has come onto the scene without having been experienced before. There are strains of coronavirus that cause illness in humans similar to the common cold. There are strains that are only circulating in different animal populations. And this particular strain is different enough. It has a sort of genetic combination that is able to cause disease in humans. And because we don't have an immune experience, it's similar to when we talk about an influenza pandemic. If that virus changes just so much that we've never seen anything like it, our body doesn't have that memory. That's why we need to get the flu shot every year, because the virus shifts and
Changes,
drifts.
right.
So this virus is different enough, and it's able to be spread in a person-to-person fashion. And what we're seeing
Is that what
for
they call community
Acquired?
Acquired, yeah.
Yeah. So when we first started seeing cases, it was consistent with a known exposure. So we saw the cruise ship, where everybody was in very close
Right.
quarters.
Right.
Then we saw in mainland China, where they had a particular province, an area where there was droplet transmission. And that's another thing for people to understand, is that this virus isn't something that lingers in the air like tuberculosis or measles or smallpox. It actually is a droplet spread. So when the virus is attached to droplet particles, when someone sneezes or coughs, it's getting on hands, it's getting on surfaces, and that is where the communicability or the infectiousness takes place. It's through surfaces or hand contact or close contact within 3 to 6 feet.
What do we know about this, and what do we don't know that we'd like to know?
So that's a really good question. What we're really acutely interested in any type of investigation of a disease of any sort, is who are the groups of people who are at greater risk. So I look at something that we hadn't experienced before in the United States, like West Nile virus back in 1999, and we had never seen that before in the Americas. And we had only had limited information about what it was doing in other countries because it was a sporadic illness. So our response was very aggressive, but that particular illness, we needed to figure out who was more at risk. Are there certain types of precautions that we can put in place to protect people depending on how something is spread? And then also, how do we message, and at some point with H1N1, which you remember from 2008-9,
Yes.
we were able to develop a vaccine. It took 6 to 8 months because that's how long flu vaccines take. We were able to then say, as that flu vaccine came on board and was available, we were able to make decisions based on risk to say pregnant women, young children, and then also healthcare providers and critical infrastructure should be the first groups of people to get a limited resource, because we need folks to take care of the very sick. We need to make sure that the people who are most at risk, so as we learn about who those populations are that are at greater risk, we can then target interventions. We don't expect a vaccine to come on board
Right,
for
right.
upwards of a year.
That's what I heard.
So, we're going to be learning about this disease as we go, and we shouldn't expect a vaccine to be available. So we're really relying on what we call the you're going to hear a lot of lingo tonight, so I'll apologize in advance, but we call it non-pharmaceutical intervention.
Yes.
And that's stuff like social distancing. I purposely chose to sit 3 to 6 feet away from both of you.
Let's fist bump, not shake
Yes,
hands.
fist bump, elbow bump.
Right.
These types. I mean,
Yeah.
they a little bit flip about it, but these are the things that go a long way. And the other thing that I like to say, my wife's a teacher, and we talk about hand hygiene, and she teaches younger
Right,
kids,
right.
and it's really about. We're talking about this around coronavirus, but we could very easily play this show at another time and talk about we should be practicing good hand hygiene, cough etiquette, stay home when you're sick,
Right.
those types of things anyway. So I'm hoping that we don't go the route of a widespread community acquired type illness, but it is helpful to reiterate a lot of the prevention messages that are germane regardless.
Yeah. So it seems to me that you people in public health, and thank God you're there, because you've dealt very successfully with some prior things that were some drastic things were recommended, which we didn't need, and the public health people turned out they knew what they were doing. I'm thinking of SARS. And it seems like that for this thing, there's the public health thing of having people not contribute to the transmission of this by being careful about what they do. Wash your hands. We're all told about that. Sing happy birthday, wash your hands, all of that, and cover your cough, and all of that. And then there's the idea that maybe the ultimate thing is the development of a vaccine. And you've already sort of talked about that's a while away.
Down the road.
But what is the major emphasis that we need to do to help people protect themselves and protect this community?
So right now, I would say that our phase of operations is certainly we in the city of Manchester have operationalized our incident management structure, because we find that that's the best way to get all of our city government stakeholders working in concert with one another and sharing information. But that also extends out to our healthcare partners, our schools, first responders, et cetera. Because one of the things that we have to be mindful of for any type of situation is that we don't want folks that are responding to then become ill, because that becomes a what we call a continuity of operations problem, where if you have 20, 30, 40% of a workforce out of work, and those folks are dedicated to healthcare, police, fire, EMS, then that just amplifies the problem. So we're really focusing on, do our partners in healthcare and first response have the tools, the training to keep themselves safe as they're treating potential patients? So that's one arm of this. The other arm is making sure that we try to unify messaging across all the sectors and having common messaging. And so the other part is, what do citizens do? What do businesses do? And so we're preparing some helpful materials around continuity of operations and continuity of government. And the way I like to frame it really for folks at home is it's similar to an emergency preparedness plan. Do you have food and water if the power goes out? Do you have all your documents in an order? For government or for business, you have to think about what are our top 5 or top 10 most critical functions that we are either legally mandated to do, or will keep the bills paid and keep the lights on for your business. And so for businesses, there's a lot of work, and there has been a lot of work about telecommuting and telework, those types of businesses where people can work remotely. So we've seen that as an opportunity. In some school districts, they've explored those options, but there are equity issues associated with that. And for government, we have statutory responsibilities as a health department that we need to make sure we're investigating diseases, that we're looking at hazardous circumstances in the community. Police and fire are also critical infrastructure as our healthcare partners. So we had a discussion with we're having an emergency operations center meeting tomorrow with all department heads to talk about.
That's the city of Manchester.
Correct. Right. And I know that the city of Nashua has had a similar meeting.
Right.
And I know other communities are also plugged into emergency management structures in their own local way. And so we are looking at the tax collector's office, what things can be done remotely? Do we have to have certain functions actually in the office? But then that begets if the public is calling, how does their call get routed? Can we route it to a cell phone? Can we, how do we do the things that we need to do? What services can be done online? We've made some strides as a government in those areas, but people have to think that through to make sure that citizens are, their needs are being met, and they're not penalized if there are things that can't happen, like bills getting paid. So it's going to take some of that minutia, but these are the things that we're thinking about as government, and businesses are hopefully thinking about those things concurrently.
So, I'm hearing in some areas that we're being told to avoid attending, large mass events. Is that something that you are going to caution people about too? I mean, should we all go down to the Snooze Center to hear a concert? Or
So that's an excellent question and a timely question. We're actually keeping track of questions that we're getting as a health department and trying to make sure that we're sharing and helping to update sort of a Q&A, and we want to add like a fact sheet of commonly asked questions. We received a common gathering question actually, I think it was yesterday, and right now I want to emphasize on March 4th, there's no community transmission. We have 2 presumptive cases in a different county.
Right.
So there's no reason to, consider changing the schedules of any common events. What I do encourage folks to do is look at cleaning and disinfecting practices at those locations. Is there hand sanitizer available? Those types of things are enhancements that can happen, and we're looking at that across many different systems to say, what are we doing now? Is there something we should do a little bit differently? The airport is part of our emergency operations structure, so their airlines, the cleaning on planes, the cleaning of kiosks, and all of those areas are being enhanced. And the way I look at it is the more cleaning and enhancements and sanitation, the better it is for all infectious diseases that are communicable in the way that flu and coronavirus seem to be.
On the other side, Phil, and a lot of people are saying, we have the flu every year. I mean, we had the horrible flu epidemic in 1918, which would kill far more people were killed on the Western Front, believe it or not.
Right.
And we that's a historical event that happened. And yet we most of us go get our flu shots, and we know that even though we do that, there's a certain number of people who are going to get the flu.
Sure.
And that can be a pretty awful experience for people. But somehow this coronavirus, this COVID-19, seems to overwhelm the concern about that. Is there a good reason for that, or is this? I mean, are we getting too excited about this COVID-19?
So the way I like to look at real-world events is that we can make a lot of the types of prevention and practice and training be more realistic, in hopes that this isn't as serious as it could be. So with H1N1, we had significant concerns that was going to be more serious and more impactful than it turned out to be. So that was actually a very good opportunity to practice with our regional partners. So we, in New Hampshire, as you said, Senator, we don't have local public health departments aside from Manchester and Nashua. So after 9/11, we had as a state to think about how do we regionalize or organize areas to respond to something like a pandemic or smallpox or anthrax, to dispense antibiotics or vaccine, not having these assets. So we regionalized that approach, and that's changed over time as how many regions. But since 2013-14, we have 13 public health regions, and each region is responsible for coming up with plans to what we call prophylax or do community clinics. So we're looking at this, whatever this turns out to be, as a way to operationalize a lot of the things that we've been planning for, I say since 9/11, but also before 9/11, we were planning for a pandemic. And this is essentially, whether it's influenza or COVID-19, we have to deal with medical surge, regardless of what it is. We have to consider these tough questions like canceling events or school or isolation and quarantine, which involves due process and a legal process. And what does that look like in today's age? We would have a video hearing versus bringing somebody somewhere where they could, potentially make people ill. So there are a lot of elements and building blocks that date back to the 1800s in terms of public health powers and infectious disease control that have evolved, and this is no different. It's just that we have to use the data that we have in front of us to figure out what's that surge going to look like, or what messaging do we have to apply to a particular population. Is it the very young, the very old?
Right.
We don't know all of those answers, but we're activating our processes that we've built for, so what we call all hazards approaches. We call high threat infections.
So I'm taking over to your
No,
little.
good.
But
We have
I'm
plenty of
gonna-
time, don't we?
Right.
I'm gonna- So you use the phrase pandemic, which we certainly are in connection with this particular
Right.
coronavirus, COVID-19. What actually makes a pandemic as opposed to something not a pandemic?
Well, that's a very good question, and oftentimes it takes a connotation. So by definition, if you are in public health training, a pandemic, the root word pan means global.
Yeah.
And then epidemic is anything that's happening that is above what's expected in either a particular area or a particular season. And so this is global, the pan part, and the epidemic part is we haven't seen this disease before, and we're seeing it in large numbers.
So is this now a pandemic?
It is. Now, what I want to caution is sometimes we use terms like pandemic. It doesn't mean that it's like the pandemic of the bubonic plague, which was killing
Right.
millions of people.
Right.
It doesn't necessarily correlate to mortality,
Yeah.
but you see those numbers in the media reported at different, what the mortality rate is X compared to this.
Right.
And so those are numbers, those are data points, but we have to think about what that actually means and try to frame it in a way that people can wrap their head around it. So we use the 1918 flu pandemic as a benchmark, but that doesn't mean a lot to anybody who wasn't around then.
Right.
And so we use swine flu of 76,
Right.
and then now H1N1 is
Right.
it. So we use different benchmarks to help people get their head around impact. And so we see what the impact is, but there are lots of variables like what's the quality of healthcare where the data is coming from.
Yeah.
How many people are being tested?
Right.
Only the very sick have been tested thus far.
Right.
So the mortality rate is upwards of 2 to 3%. Now, is that because we're only testing the most sick? There's evidence that suggests that the illness in a certain percentage of people is very mild, or people are asymptomatic, meaning they don't have symptoms. So do we know that? We're learning what's happening in the Pacific Northwest. One of
Right.
the universities did some genetic testing to look at the virus there versus the virus in China, and there were subtle differences that would suggest, based on what we know about these types of viruses, that it may have been circulating earlier than we started doing testing and seeing significant illness, which says that maybe there are a lot of people, or a significant number of people, that were not that sick, which would mean that overall the mortality rate isn't as big. But we don't know because those people weren't tested. You go to the doctor, you get a rapid flu test.
Right.
We can say it's 0.1% mortality rate. So we don't want to get too honed in on the numbers. It's really about impact.
Right.
Because for me, the impact is people, maybe going to use the healthcare system when they don't necessarily need to. We know our hospitals are running
Yes.
at the margins every day. So what does that mean? Or if things are canceled when it's not really prudent to cancel them, what happens when mom and dad now have to stay home
Right.
for a reason that isn't based in evidence? Because then that has business impacts and family impacts, and so it's very complicated. So we don't. I know that when I talk to my partners across the state and other places, when we take a public health intervention or action, we give it careful consideration to balance all of these factors. But right now is the time to say, if you have been to Italy within the last
Right.
14 days, this is our chance to keep things from becoming a community issue. This is our opportunity. They don't have the benefit of that right now in other parts of the world,
Right.
in other parts of the country, it seems.
Yeah. Well, I think a couple of things came into play.
Mm-hmm.
And the first thing was the reliability of the data coming out of China. And we question that to this day as to
Yep.
when it really started,
Right.
what was the intensity of the problem, and how was the problem treated. I mean,
Mm-hmm.
in this country, you can't just shut down a city of 3 million people.
Absolutely.
All right, and that was done.
In
That was
China.
done in China.
Amazing.
So the word would say, if you're shutting something down, 3 million people, if the streets are barren, there isn't any food. First of all, how do you feed them? How do you treat them? What's going on? And so reliable data is so important. As more data has become available, I think we've kind of looked at this in a number of different ways. And I think the first way is, how severe was this problem in China in terms of how it was reported? And then we noticed what was happening. Italy. Why does Italy have 500 cases? Why is the city
Specific
of
to
Milan?
northern Italy.
Yeah. Why is the city of Milan shut
Yeah.
down? I have relatives in Milan. I have cousins and aunts and uncles who live in Milan. They've shut the schools down for 3 weeks. People are a little fearful of leaving their homes. I think the Italian Prime Minister has brought forth a suggestion to shut down all of the schools in Italy, to just close them down. So why is it there? Why is it in Iran, which is one of the more closed societies in the world? Why has it appeared there? How do we get a handle on these questions in terms of how it will then affect us? Because we knew it was coming. Anybody that said it wasn't coming was lying to us.
Just
And
by the nature of the way we travel.
Right, and giving us a false sense of security. And the first thing I think that we should have done as a nation was, our Department of Health and Human Services on the national level should immediately been brought forth to put into place what's available to them in terms of the network of addressing this situation. We appointed the vice president, doesn't have any medical background, and shunned aside some of the people whose lives were dedicated to this kind of work. And so we're behind the 8 ball, in my opinion. So I believe it was the House that appropriated $8.2 billion today to deal with this. $8.2 billion. How's that money going to get to the communities?
So
How's
it's
it going to get to Manchester?
So luckily, I had the benefit of taking a sneak peek at that. Our congressional delegation and our state health department and the governor's office have all been working across lines to look out for the best interest of the citizens of New Hampshire, to everyone's credit. So I have faith that, when it comes to taking care of citizens, ultimately people are going to do the right thing, and I've been encouraged by that. What it looked like today, based on the breakdown, there's a certain allocation in different areas, one of which was sort of the prongs that I talked about earlier. There is a vaccine development prong.
Yes.
I forget, like $3 billion. That would be for next year. Or if this becomes like influenza, where it changes every year, then that would have some absolute benefits. There is money that is going to be dedicated to reimbursement of communities and states, knowing that we have budgets, and as a health department, our budget is reliant on 20 some odd different grants, and that's almost 50% of our staff at the local health department is funded by a grant in some way or a chargeback. So we're very reliant on different programs. So if we're working on a program on chronic disease, that doesn't give us the flexibility to pivot into, now you're going to work on coronavirus, because we're beholden to what those grant deliverables are. So in those instances, we would have to consider reimbursement. Now, we do reimburse, or the federal government does reimburse for presidential declared disasters through FEMA at I think it's 75%.
That's correct.
But that doesn't exist in public health automatically. So I'm as someone who has to allocate resources and look at what we might have to do, I'm comforted, as other communities should be too. If we had to open up clinics, it's going to rely on overtime and all of those things, because we don't have a workforce of public health folks to just deploy everywhere. So there's money for vaccine, there's money for reimbursement, there's money for health providers. To my point before, we need to make sure that that system is well protected, that they have the personal protective equipment that they need, which we've heard a lot about. And I would caution people to think very carefully about not stockpiling masks because masks are good for people that are sick and don't want to spread viruses or other things to other people. But people are also buying respirators, and respirators are devices that need to be specially fitted to your face to protect the user. And as people stockpile these things, they're not available for the people who are going to be taking care of you when you become sick. When you take your hand on your mask and then contaminate your eyes and nasal passages and then introduce the virus after you've taken your mask off because you haven't been taught proper donning and doffing of personal protective equipment. So people will want to react very strongly, but think about the bigger picture and keeping all those things in mind. We're part of a bigger community, locally, statewide, and globally, and everything we do has impacts across those systems.
So those, if I could, Bob, just one more.
Please.
Those are some of the do's and don'ts. But what are if we could list what should people do, and we could categorize what people shouldn't do.
Okay.
And one of the things that seems to me that's happening is they're buying Clorox. The shelves are empty.
Yeah.
I mean the hand sanitizer.
The hands and Clorox.
Yeah.
They're just, the shelves are empty. The hand sanitizer, you can't get them.
Yeah.
People are stockpiling these things. Is that a good thing to do? I mean, or should we be listening to people like the health department? These are the things that we should do, and simply the first thing is, if you get questions, go to the website.
Yeah.
And follow the information that's available.
I think it's human nature to want to take action immediately.
Right.
You brought your own, that's
Yeah.
good.
Here it is.
People want to take immediate action and do something because
Right.
inherently you want to feel like you're able to take care of your family in an immediate
Yeah.
way, and I think that's
You
increasingly
don't want to feel helpless.
so. People are going to probably scoff at these notions, but the best way to protect yourself from something that is a droplet spread infection, something that's not floating around, is to wash your hands
Right.
if it's available. And if you don't have hand washing available, then hand sanitizer is useful in this instance. But I will say this to folks, if they are like, well, I'm just going to use hand sanitizer all the time, and I work in public health, so I'm always thinking about the what ifs. There are some things that the hand sanitizer doesn't work against, like norovirus, which is the very bad gastrointestinal illness, that is really not effective. So hand washing is always the primary goal. Now, are there some common sense things that
Yes.
I would do?
Yes.
I can tell you I went on a trip, not to one of the affected areas, so that's not why I'm sitting further away from you. I had to inject a little bit of levity here. And I didn't really think about common surfaces as much as I did this
Right.
time. So did I have my own wipes to wipe the handles on the airplane and the tray table? Yes, I did. Okay, so I will fully admit that.
I'm going to do that next time. I hadn't thought of that.
Because I'm not confident that in the time that, and I'm not saying it doesn't happen, but in the time that people are getting off and I'm getting on, I don't necessarily think that's humanly possible. So that would be a prudent
Right.
thing to do. But it's really about your own behavior is as much to do with your risk of any infection. Because if you were to videotape yourself, and I know teenagers are doing videos all the time. I have two of them, and they're making videos. I would like to count how many times they're touching their face in
Right.
some way, and those are all opportunities. So thinking about just some of those common sense behaviors and just paying attention. I mean, right now, like we talked about, we've had calls about, should I go to this event? Should we do this?
Right.
And right now, the answer is absolutely you should do it. There's no reason to
Not to do it.
cancel
Don't
things.
panic.
But there are some things that, we probably should make hand washing stations available. I mean, or hand sanitizer dispensers, maybe more than we thought about before. Or maybe we're going to do all the doorknobs and hand plates on certain doors that maybe we didn't always do them.
Right.
And so these are things that we can do, and then hopefully we continue to do them anyway afterwards.
Well,
But those are
Yeah.
the things that will help against any infection. I also often say that as well.
and it's simple. Wash your hands.
Well,
I mean,
It sounds
you know,
simple.
you know,
Sounds
and
simple, but we
I'm
don't do it.
astonished. And somebody told me, "Be careful about how many times you put your hands to your face." I wasn't aware how often I did that.
Oh, yeah.
I mean, I just do it all the time, and I never
Sure.
thought about it.
Well, we do it as
And
a
now
course.
it's a hard habit to break.
Right.
But the next thing I wanted to bring up with you, Phil, is the how good is the data we get? I guess the Centers for Disease Control in Atlanta is a key part of our public health
Yep.
for the whole country, and we're hearing about. Do we have the testing kits that we need
Yes.
to
good
test
point.
people? And are you getting the support from the CDC that you need? And are these kits, are the update that we need? Are they doing the job that we need? And are there enough of them?
So that's a great question, and these are questions that we've also taken at the health department. And our partners at the State Public Health Laboratory in Concord they do a phenomenal job, and they are very competent in what they do. They were able to, in very short order, obtain the reagents. And I just want to, this is kind of into the nitpicky stuff, but when we say test kits, when you go to the doctor's office, they take the swab, they put it in the thing, and if it turns a color, I'm oversimplifying, you have strep or the rapid test. Those are packaged kits. In these instances, what we mean by test kits is a little bit different, where a certain type of series of swabs will be taken, they will be collected, they will be delivered to the state public health lab, and then they have to do analysis there. So it's not an immediate test. There's a 24-hour turnaround, and it involves protocols. So there's preparation. There are what we call special reagents that have to be properly calibrated, and the methodologies have to be tested. So they had to develop methodologies that were sensitive and specific, meaning they were able to detect the virus but not do it in a way that gives you large amounts of false positives or false negatives. And so the State Public Health Laboratory has the ability to do these tests now, which they didn't as of, I believe, Monday morning. And so they have that capability now. And they are then, if it is negative, then the test will still go down to CDC for a secondary confirmation test. But if it's positive, we call it a presumptive positive. Now, does that mean we say, well, we're not really sure? Because I think some people might think that if it's a presumptive positive, we operate in public health on the assumption that that is a positive. We are going to take public health actions based on that until we're told otherwise. So we don't say, well, we're not 100% sure. We are sure enough that you're going to be isolated at home. And another thing that often gets confused is when we use the terms quarantine and isolation. People who are isolated are ill, and people who are quarantined have been exposed potentially, and we are monitoring them to see if they become ill. Essentially, it's similar, but in the eyes of the law, those are two distinct scenarios. But basically, we do have the ability to do testing. The testing criteria also has changed, and it probably will continue to change as we either get other countries that have widespread transmission, or we have, hopefully not, more localized transmission here. And any health partners that are listening to or watching the show, the protocol has been delivered to all of the health delivery systems about how to request this particular testing and under what conditions. And that's through the Department of Health and Human Services sets that criteria. I know that's a long-winded answer, but we do have the ability to test in New Hampshire, which we didn't have last week.
So we have the technology to test that we need. It's
Yes.
just a question of deploying it.
It's a question of determining who the appropriate cases are or potential
Right, to
cases
use
are
it.
to test.
To use it.
And so that's another thing that clinicians and even the public should know might change based on what we know about the illness.
So I have to ask you, and you probably will find this very tough, because where do you think we are on the curve of this thing? Do you think, a vaccine might be a year, 18 months away, which is actually pretty amazing that we could, develop something in that time frame.
Yep.
But that's a long time.
It
for,
is.
With the spread of this disease, at the rate it's spreading. And so in the meantime, we're dependent on folks like you all around the country to do the public health thing that you do, helping people understand how not to, contact or transmit this virus. And what do you foresee? Do you have any idea where we are on the curve of this thing? I mean, compared to the prior experience you had with SARS and MERS and whatever?
Sure. So, my mind always goes to let's plan for the worst case scenario. And, we are fortunate that we don't have localized transmission in New Hampshire. And so, but we're talking about things like your business, your health system, your school might have these significant impacts based on what we consider to be the worst case scenario. So we base our planning on how bad it could be, and we hope that it doesn't get there. But we're talking about what steps do we need to have in place should it get that bad? Do we have the materials we need, the personal protective gear? Do we have proper levels of ventilators and oxygen? And so our health systems are kind of inventorying and figuring out what their assets are. And we do work, because we're a small state, I will say this, we are very good at helping one another out across all of our hospital systems. We have hospital systems that are competitors in some ways, but when it comes to emergencies, everybody is in it together. So I like working in that space in a strange way, because we all have common interest, and that's taking care of our citizens and visitors. So we could be going down a road of seeing sort of a ramp up of activity. What if activity translates to impact? That's unknown. We could have a lot of people test positive, but maybe not a lot of impact. We could have some people who are really sick and may have a big impact on the healthcare system. Or, as we talked about before, if you have facilities where people are more susceptible, they have to be even more vigilant. And a lot of our facilities, like long-term care facilities, have to be extremely vigilant if there's any hint of a virus or a bacteria infection or anything, because of the immune status of their residents. And so we that's again comes down to what we call precautions.
Sure.
So, we're gonna see what happens, but I want folks to know that there are a lot of these principles of doing contact investigations. It all happens behind the scenes. We don't say, we're watching these people for privacy reasons, but just know that people in public health are out every single day of the year, visiting people at home to make sure that they're well, that if it's an infectious disease that requires someone to be on a particular medication, like tuberculosis, we are not, health department representatives are making sure that people are doing what they need to do to keep everybody else safe. And not a lot of fanfare, granted, but I want folks to know that we do this on a regular basis, and we apply these principles in scale, and that's what we're trying to do.
And you must have as a priority to protect the healthcare workers. I mean, they're the people that are coming in contact with people that have been exposed to this thing.
Yep.
And you got to be really concerned about them, because, my gosh, if you get sick, you want the healthcare worker not to,
Absolutely.
head the other way. You want that person to help you out.
Well, we learned a lot of lessons during the Ebola crisis or issue that we dealt with several years ago, where a lot of these infectious agents, it seems like they come in waves, and there's a gap. And I'll just say from experience, we had a lot of funding around emergency preparedness right after 2001, because we had very limited plans. We built plans on how to dispense, and then it seemed like, okay, well, we've done a good job with that. And then we had H1N1, where we started to think about, we need to dispense vaccine, but we might have med surge. So do we have oxygen? Do we have all of these elements? And then we have a dip, and then we had Ebola. And what we find is that, there may be funding coming our way. That's great, but it always goes away.
Right.
And that is a problem, because you have what gets cut? Equipment and training.
Right.
And when you put those lack of training and equipment together, you get people who misuse personal protective equipment. And at least one of the cases of Ebola in a healthcare worker in Dallas was the person, not to their fault, wasn't properly trained, and they didn't practice. And that's usually what happens from my experience is, we're going to have this, but we don't we can't just move off of it. We have to realize that there are certain building blocks or elements of preparedness that have to be practiced, whether it's a real world event or not. That's important not to lose sight of, because things will come around again with a different name and a different, impact potentially. But we are always practicing. That's the key.
So if people want to have information,
Mm-hmm.
I think you've already adverted to this, apparently a good place to go would be your website, right?
Absolutely. So what we can do is I can provide a link for the viewers to see that we can overlay, and that will direct people to the state's health department, because I know we're going to be joined by viewers from across the state, which is wonderful.
Yep.
And that is the best place to go, because the state is updating, and you can even see the progression of some of those updates. Instead of having to go, I'm going to go to my town, which might not have the time to update it in a timely manner, because they're working on this plan. So in order to do, so we're as a health department, we're going to be, and we have been directing people to the state's health department website, which they've done a wonderful job keeping track of ever-changing guidance. And again, we have to condition folks that the message is going to change, and it's not because we don't know what's going on. It's because this is fluid.
Yeah. So you still shake hands with people, or do you do fist bumps now?
Today at a meeting, I approached somebody like this, and they knew what I was doing. They didn't expect me to 2 minutes for elbowing. It was more.
Lou and I are politicians. We're used to handshaking.
So if you do, you have a perfect non-pharmaceutical intervention between you guys. So I think sometimes there's some merit to some of those customs, and right now it's probably a good time. I'm a soccer referee, and one of the things that we did years ago is we used to do the handshake with everybody. Now we do the fist bump. Although I get a little worried that they're going to try to fist bump me in a different way, depending on how the game went. But so I kind of but yeah, I mean, I think we just have to be mindful, and I'll say this again for the fourth or fifth time. Before, when we saw coronavirus was happening in China and we didn't know a lot about it, there were lots of flu A, flu B, and even norovirus circulating around, and all of these messages are germane across the spectrum of what seem to be these winter illnesses that we experience seasonally. And so, it's always good information.
Yeah. I think part of the problem is we live in such an interconnected world now. People think nothing. I mean, last week I was off to London to see my son that lives there, and, interesting to be going home and they just don't ask you, did you pack this bag yourself? But have you been to China? Have you been visiting anybody from Asia? All of this interconnectivity. And is it just me, or does it seem like we're getting these kind of crises, these coronaviruses, of which this is just one variety, is more frequent, and we're having to deal with this problem more often than we used to, with all this interconnectivity around the globe between the airlines and everything?
So I think from day one, working in public health, we've always been very mindful of that global travel element. And so anything, whether it's commerce items and goods and goods, can be delivered across the globe in a matter of hours. That's no different than people. To this point, we haven't had something like this with this level of intensity. And I think, to your point earlier, the level of attention, the social media immediacy of everything, and then the lack of confidence in some of the data, all of this comes into play at the same time. And some of these elements probably existed during other issues over time, but because of that intensity on all of those fronts, I think we are having an overall level of intensity that's more than before. How that plays out, it doesn't change what we're going to do to prepare to be ready to tackle that. It just, I agree, it causes some pretty strong reactions and actions. I just hope that as hopefully resources come to communities and states, that we have the flexibility to use these dollars in ways that are going to be helpful not only for this, but moving forward.
Sure.
So across, kind of that spectrum.
You know, do you worry about a danger of an overreaction to this? I remember, I think it was Ebola. There was, I think of one governor in New Jersey was going to, insist everybody be absolutely quarantined that had been anywhere near. I guess it was West Africa that came from, right? Mm-hmm. I mean, that seemed like it turned out the public health people knew what they were doing. They were able to, really limit the effect of that in this country. Oh, we have a call. Let's take a call from Sandy.
How do we get it?
Just press the button right there, Lou.
This one?
Oh, right there. Hey,
We
hey
got
Sandy. Hi, Sandy.
Hi there. Hi, Lou.
Hi, Sandy.
Bob.
How are
Hey,
you?
welcome back.
How are you doing?
Doing just fine.
I'm listening to this, and hold on a minute. Let me turn my TV down. I'm sorry.
While you're doing that, I'm going to use some of this hand
Oh, Lou, you still look good.
Thank you, Sandy.
I hope your people in Italy are okay.
Well, thank you. Thank you.
I'm just wondering, I was going to ask this gentleman, do you think it's out of place? I went into a store today, and there was a little girl, actually, it was the families of transition, and she was coughing away. And where my daughter's a nurse, she's got her BSN and a minor in psych. But anyway, I wash my hands constantly. I worked with elderly for 18 years for Manchester Housing. But I said to her, sweetheart, I think you ought to be wearing a little mask. And the older lady came out afterwards and she said, I think you ought to go home. So I'm thinking, okay, because I think people who have, she was coughing, and then she said, yeah, I've been coughing, and there's a lot of people that go in and out of there, and a lot of them are elderly people, a lot of young people too, anyway. So then I thought to myself, was I out of the way? And then I said, I don't think so, because it wouldn't bother me. I keep 3 or 4 little ones, from the hospital. I just keep them in my pocketbook in a little plastic bag.
So thank you for your question.
And, I figure if someone's going to start coughing next to me and coughing, I'm going to put the thing on. I never have had to put it on. But, this gentleman's speaking very well about this.
Yes, he is.
Well, thank you.
Yeah.
But
I agree with you, Lou. I read the article about that young Chinese doctor that passed away. Who had
34
a wife and was pregnant.
34
Really,
years old.
I thought that was terrible.
Yeah. I
You
think,
know?
whoa. Yeah, I mean,
Mr. Lee, I guess his last
Dr.
name was
Lee.
Lee or
Yep.
Lou,
Yeah.
and he passed away, and he was trying to warn them almost a month before, and what they did is they made him rescind his statements and so on in China. I thought that was kind of too bad,
Certainly
well,
was.
there's a question about bad information.
absolutely.
and-
Oh, is there really?
Well,
Yeah.
the Chinese were not forthcoming. Again, that's my
No.
my opinion. I'm no expert on it.
Tendency in authoritarian
right,
regimes,
right.
if they're not
But
very forthcoming.
They
about
weren't
problems.
forthcoming on the level of the disease and
Right.
the severity of the disease. So,
Well, I'll tell you, I'll leave you on this note. My granddaughter was supposed to go sing in Taiwan with her professor. She's studying music education and speech pathology at Gordon College in Wenham,
right.
Mass. And finally, Sunday, they said, okay, we're postponing it, we're canceling it.
Right. Well,
And
I,
That's happening to a lot of foreign travel.
Yeah.
probably a wise decision
Yeah.
at this point.
Definitely. I don't know why they put it off so long. Well, anyway, good luck to both of you. Hope your families keep
Thank
well,
you.
Bob and Lou, and
Thank
that
you.
gentleman got some information, and glad to see you both up and around and healthy, and you take care.
Thank you,
Okay.
And
Sandy.
give my love to Pat.
I will. Thank you, Sandy.
Thank you, Sandy.
You're welcome. Yeah.
I think the key is communication in our society, and that's in my opinion that's been one of the real problems. We're going to have legislators together on the 10th. The Senate is putting a series of committees together to get a briefing from public health. I think that should have been done immediately. we've taken some time, and I understand that. But as soon as this thing broke, people should have been notified, and at least there should have been an explanation. And I think the reason why it intensified here is what happened on the West Coast. What happened in Washington is driving the train for us, because there are those who say, well, it would never come to America. And yet, people in public health, even at the Center for Disease Control, were saying that, but they were being suppressed for a political situation, which is nonsense. I mean, public health is most important. Our health and safety. I mean, that's the most important issue, and I think that was suppressed. And as a result of that, we're getting this late start. So communication important. Now, I spoke to my colleagues in the Senate today. Of the 13 cities in the state of New Hampshire, there are only 2 health departments. Now, of the 300 towns, or the 200 plus towns, how many of them have a health officer? Some, but the school nurse is usually the health officer.
The local GP.
Right,
Yeah.
in the rural areas, and that's where rumor and gossip becomes the number one product. So we got to suppress that, and people have to get good information. And I think the fact that our health department is working with others, the hospitals are working with others, that's a good sign in terms of getting the good information out there. The test kits, I understand that we had 100 more test kits arrive in New Hampshire. Is that true?
So I don't know the exact number. It's more about the how much capacity do they have based on the materials to do the tests.
Yes.
But it's definitely, they do have the ability to do it in state, which certainly speeds up the process. Otherwise, it would have to go down to Atlanta. But if I could take a quick second to
Sure.
address the caller's
Great.
question or concern. Certainly, this really speaks to if somebody is ill, they really shouldn't be out and about.
Right.
Putting on a mask if you're sick is appropriate if you're in a clinical setting, going to the doctor to prevent, for places you absolutely have to be. But for people who are buying masks to wear them around to protect themselves, I think we covered that that's not helpful.
Not effective.
Right.
Yeah, because you're likely to contaminate your hands and then your face
Right.
later. It's not airborne. Like that is, the purposes of a respirator for a worker who's working with patients with something that's airborne is to have a device that's molded to their face to protect them with a tight seal, whereas putting a mask on a patient is to stop those droplets from getting to everybody else and getting on surfaces. So that's important. But I do think it's absolutely appropriate, especially if there's a worker, to say, you know what, you could make other people sick. It's important.
Right.
I'm sure I've also heard of the issues around not having sick time, and these all confound one another with messaging and practice, which we could probably talk about at a later date. But I think it's important, to note that, when we saw what was happening in the first HON or health alert from CDC came out around the 27th of January, thereabouts, and shortly thereafter at the next Board of Mayor and Alderman meeting, we felt it necessary to do a briefing not only for the school board, but also for the Board of Mayor and Aldermen to say, just so you know, we are talking amongst our partners. We have plans to deal with these types of issues. We just have to know more about the situation. And now, knowing what we know, we've ratcheted that up to we're meeting, we're looking at assets, we're revising things that need to be revised, and hopefully, we won't have to put them into full effect. But if we do, we will.
Yeah.
Well, I think
So we're pretty much at the end here, Phil, and I want to thank you, and thank you, Lou, for
thank
getting
you.
Phil to be our guest. It's been an outstanding, I think, an informative hour. If you got any last minute thoughts for people about what they can do to help protect themselves and their loved ones, this would be a time to, maybe reemphasize that. I think probably going to your website, get a lot of good information there, right?
Yeah, the City Health Department website is going to have a dedicated location in the city's actual website. It's going to have its own face page after our emergency operations meeting tomorrow. But those are all going to link to specifically what's happening at the state's website, because we really, in all emergencies and all incidents, when communications are muddled or inconsistent, it breeds mistrust and and people taking actions that may or may not be prudent. So we definitely, want folks to go to one place. And certainly, if people have questions after they go to the website, there are numbers there for folks to call with questions, as well as providers.
Okay. Well, thank you very much. This has been an extremely informative hour and a very timely topic.
Yes, thank you.
And and it's
thanks for
really a
coming.
privilege for you to be with us. And thank you. And I'll be back next week with Mike Farley. Lou D'Alessandro will be off doing good things for people as he always does. But I'll be back with Mike Farley, and I'll post up about what that show's going to be about because I don't know yet. But that'll be happening. And thank you all, and thank you, our caller, Sandy, and we'll see you next week. Take care, everybody.